back of your head, maybe do these every couple of weeks just to make sure that you remember it. Otherwise, it's going to be hard to reteach yourself when it comes time to take the NCLEX. On to cellular fluids. Okay, skipped pages too fast. Sorry, on my notes here. So, cellular fluids, intracellular, right, located in the cells. This is review as well. Those are rich in potassium, and this is about 2/3 of your body fluids, typically in adults. And then extracellular fluids, obviously outside. Those are in the vascular area, intravascular. So those are in the blood and lymphatic vessels, as well as in the interstitial area, which is between those cells, right, and outside of the intravascular vessels. So those are the ones that have lots of sodium, and this is about 1/3 of your body fluids. So important for pediatrics, right? Why are infants and children at a greater risk for these fluid volume imbalances, right? Well, newborns have about 75% total of their water, right? The body is water. So they have that highest percentage of body water throughout the lifespan is basically at birth. Those NICU babies are even higher and or worse, right? And newborns have the tiniest little stomachs. We're filling at birth maybe a marble full of what we're able to take in at a time. Hence why they feed every 2 to 2.5 hours. You get a little bigger as infants, and we're going down to 65%. And they still have that high daily fluid requirements, and they don't have a lot of reserve, right? They don't have a lot left in them because their stomachs are still pretty small. And children, we're down to about 50%. Their kidneys are immature. They're unable to either conserve or excrete that effectively, right? They're still kind of trying to figure out what they're doing with themselves. And then the older we get, the better off we are, until we get to be geriatric, right? And then we're kind of back to that same stage of not being able to conserve or excrete effectively. So here is a chart of maintenance fluid requirements, and this is very, very important. And if I were you, I would print this out as well. This is something that will be helpful for you on a pediatric floor. Once, I think I was in peds for about 6 months, I had this memorized. I don't work inpatient anymore, so I have to look at it again myself, but it's definitely something that you need to have to get into clinical with. So this is also based off of a healthy child. This is not based off of a sick kiddo. So this is a maintenance for a healthy child. And this does not include neonates. They typically base their fluid or their requirements off of calories as opposed to the actual fluid itself. So take a peek at this, 0 to 10 kilos. You're going to be giving 100 mils per kilo per day. And what that hourly rate is off to the side. So if you have a provider order maintenance fluids, right, for a kiddo, this is how you're going to figure that out. Sometimes if we're a little extra dehydrated or they want to give them a little bit of extra fluids, possibly before discharge, they're going to order maintenance plus 1/2. Which again is pretty easy if you think about it, but can be intimidating just hearing it. So maintenance plus 1/2 would be whatever you're seeing here, right? Whatever we decide our maintenance level is, divide that by 2. So let's say our maintenance, this is an easy one, is going to be 10 mils per hour. And we're supposed to give maintenance plus 1/2. So 10 divided by 2 is 5, right? 10 plus 5 is 15. So maintenance and 1/2 would be 15 mils per hour, okay? And I actually have another practice here that we can figure out. So we have a 9-month-old who weighs 8.2 kilos, okay? So we say, well, which formula do we use? Oh, what were we doing off that table? We'll go back real quick, right? So if we're at 8.2, we know we're using the 0 to 10 kilos one, right? So that is 100 mils per kilo per day, okay? So we're gonna do 100 times 8.2, which gives us 820 mils per day. Well, that's not really going to help us. We got to figure out per hour, right? So we take that 820 mils and divide that by 24, and that gives us 34.17, 34.2. Honestly, if you're using an IV, you really don't have to have the 0.2 in there, but let's be specific because maybe this kid's really dehydrated, right? So let's go with 34.2. That's what we would be giving per hour if we had IV fluids on this kiddo. The daily requirement, like we said, that was 820, and maintenance and 1/2 for this kiddo, right? We're going to take 34.2 and divide that by 2. You're going to get 17, and 34.2 plus 17 is going to be 51.2. So that would be our maintenance and 1/2 for this kiddo. And if this baby is taking a bottle every 4 hours, how much would we need to feed every 4 hours? I'm going to let you guys figure that one out too. We can talk about that more live, okay? Now, intake and output. Again, this is kind of a review. We do this with grown-ups, we do this with kids, we do this in geriatrics, all ages. We're going to need to be recording their intake and output closely. Make sure I'm on the right slide here, sorry. And an expected amount for infants and children who are less than 60 kilos is going to be 1 to 2 mils per kilo per hour. Children who are bigger, greater than 60 kilos, and you will get big kids in pediatric floor. I had a 17-year-old football player once who was 240 pounds, and it was like, you don't really belong here. You kind of belong in grown-up world, but still considered pediatric, still on the pediatric floor. So we definitely want to make sure we're doing daily weights. Difference in kiddos, of course, is you're going to have far more diapers than you would in grown-up land. We want to make sure that we are scaling out the scale or zeroing out the scale appropriately. So you put that dry diaper on, put it to 0, take it off, and then put your diaper on, and that's how you get what that output is for that kiddo. So funny story, when I was working in pediatrics, my son was about a year and a half, and one night I was very sleepily changing his diaper. And I reached over after I was done to put it on the scale. That didn't exist, of course, because I was at home in his bedroom, but I was in such a habit of weighing diapers and not throwing them away that I ended up trying to weigh my child's diaper in the middle of the night. That's what happens when you're exhausted and have no sleep, right? So here's some practice. So Marcy is 22 kilos and she has voided 620 mils in the last 24 hours. So is this enough for her? Are we happy with her output? So we know she's under 60 kilos, right? She's only 22. So we're okay with 1 to 2 mils, right? 1 to 2 mils. So we have 620, which is what she's done in the last 24 hours, right? We're going to divide that by her weight, which is 22 kilos, and that gives us 28.2. Well, we need to know how much per hour, right? So we got to divide that by 24, which gives us 1.17 mils per hour is what she's put out. So yes, right, that is between 1 and 2. So we feel good about that one. We're happy with it. Alterations in fluid. So we have a fluid volume deficit, right, which just means we don't have enough fluids, okay? Those are things like dehydration. We're going to get that from a GI bug, vomiting, nausea, diarrhea, unable to keep fluids down, and then a fluid volume excess. This is caused by that water or sodium retention in those vascular and interstitial compartments. Examples of that are congestive heart failure or chronic renal failure. You're going to see less of these kids on the general pediatric floor, but it is still possible. More likely, if we've got a kiddo with known heart disease, a lot of times they go over to the PICU just for better monitoring. And sometimes they go into like a pediatric oncology unit because those are considered clean floors. Whereas if you put a kid with heart disease on a general pediatric floor, there are so many bugs flying around. You don't want that heart kid to get sick. So let's talk a little bit about the fluid volume excess. That can cause those bounding pulses, those neck veins that get a little bit distended, hard to see in little kids, right? Because they're chubby and they have no necks. You can get some of the periorbital edema. You can get an enlarged organs, especially the liver, a little bit of shortness of breath, and definitely those crackles when you're listening. As far as fluid volume excess is concerned, you have to treat whatever that underlying disorder is. You may anticipate an order for some sort of diuretic, some Lasix, things like that. But again, this is not typically what you'd see on a general pediatric floor. A lot of times these kids go to the PICU. So fluid volume deficit, we're going to see this more frequently. So isotonic means that our fluid loss is not going to be balanced by what we're taking in, right? More is going out than we're able to take in. So and this is review too, we should mostly be familiar with this. The loss of water and that sodium is going to be the same. We're not uneven there. So this comes from those GI bugs, the vomiting, the diarrhea, things like that. An isotonic fluid would be just your regular normal saline, 0.9 normal saline or your D5W, okay? That can be given through a regular PIV, no problems with that. Hypotonic fluid volume deficit is characterized by greater loss of water than sodium. So way more water's going out. We've still got that. And that sodium's not going to. So that serum sodium is low. We get a shift from the extra outside to intracellular, which is going to give you higher level of dehydration in that outside area. This comes from, you're not going to see this in a kid who, you know, just started throwing up yesterday and has been able to keep some fluids down. This is some severe prolonged diarrhea. You may have renal disease, and this is also common in burn patients, which I don't think we cover in pediatrics. I think you cover that later on. So a hypotonic solution example would be your half normal saline. Hypertonic would be that fluid loss that it has more loss of water than soda, which I think I have a typo in there, which I will fix. So your serum sodium is high, right? You've got more sodium out floating around. So the onset of your symptoms usually are delayed because you have those compensatory shifts again. This comes from things like diabetes insipidus, and a hypertonic fluid would be like D10W. You're not giving that in a general pediatric floor. This kiddo is going to the PICU. This is not something you want to be trying to deal with while you have a higher patient load. So on to our exemplar. I'm sure you guys have heard that word 6 million times. We are looking at dehydration specifically. So we go back to that history and assessment, right? Who is most at risk for this? So we've already talked about this a little bit, but this is going to be the infants and small children, right? They have smaller stomachs, and you can't convince them that they need to drink more because it's going to actually make them feel better, right? Anybody ever have tried that conversation with a 2-year-old? Does not work. So again, you want to ask parents, guardians, whoever's there, that old carts and news questions, because that's going to help us figure out how dehydrated they are. How long this has been going on, and maybe everybody else in the household's been sick too, and they already know what it is. Again, that's a big help. So check out our overall appearance and behavior, right? Are we crying? Are we awake? Are we laughing? Are we giggling? Are we sleepy? Physical assessment. This is, again, all things that you guys should be doing. Vitals, height and weight, and especially when you're looking at dehydration, you're going to pay attention to the mouth. Is it dry? Is it cracked? Do we have tears? Do we not have tears? Just because we have tears does not mean we're not still dehydrated. That's kind of a later sign. That's a, uh-oh, we've missed something kind of sign. So as far as diagnostics go, I think we've got that on the next one. We don't have it on the next page. I swear I have it on here somewhere. Yes, I do. I have it later. Sorry. Causes of dehydration. Emesis, of course, we know, vomiting, diarrhea. As far as diarrhea goes, there is the rotavirus, which when I first started out in pediatrics was a big deal. You could walk down the hallway and you knew somebody had rota in the hospital. You could smell it from that patient room. Like that whole hallway stank like rota. Thankfully, they have come up with a vaccine for this. So babies get it as a liquid oral vaccine. They get child checks, and it basically has gotten rid of the problem of rota, which causes severe dehydration in kiddos. C. diff, this is why our history is so important. We know C. diff can come after we've had antibiotics, right? Maybe this kid just had an ear infection and was on Augmentin for that. So it's important to ask those questions. Less common, of course, would be something like parasites. We'd be getting hepatitis, things like that. But again, something to think about. Dehydration causes could also be failure to thrive. I had a parent come in one time with a 2-month-old little boy who was definitely dehydrated, and she didn't realize that she needed to be increasing the amount of formula that he was getting, and her concentrations were off on what she was doing for formula. So he ended up being severely underweight and dehydrated because of that. Economic issues are also something to think about when it comes to formula specifically, right? We always want to make sure that we are mixing the formula to the directions on the bottle, mostly because it can mess up the electrolytes on that. But sometimes, we're going to end up with dehydration because, they aren't able to buy Pedialyte and the kid's not keeping anything down, things like that. So here's some better diagnostics there for the fluid and electrolytes. So kind of like before, right? We can run a CMP or a BMP. It's going to give us our electrolytes, our CO2, which is really a big thing that we look at in pediatrics as far as dehydration goes, right? If our CO2 is down, we know this kid needs some fluids. Your BUN, your creatinine, your glucose, all things that you look at normally, right? You can get just a BMP in kiddos, but if they're coming in and it's their initial diagnostic there, usually the provider is going to want more information. If you have to poke a kid already to get labs out of them, the best you can do, or the nicest thing you can do, is only poke them one time, especially if they're already dehydrated, because it's not going to be an easy poke. So get what you can the first time. CBC we've talked about. UA, that spec gravity is normally 1.002 to 1.030. And you know, the higher that spec gravity, the more that kiddo is going to be dehydrated. So as far as ABG goes, we'll talk about that more here in just a bit. They are not routinely done by any means. An ABG is not typical on a kid coming in unless we are severely dehydrated and the kid's going straight to the PICU, came in by ambulance, something along those lines. So as far as categorizing dehydration, this is not something that you necessarily have to do officially, but it's really helpful as far as what to be anticipating from the provider, things like that. So you're looking at their thirst or their skin turgor, what their pulse rate is, their respiratory rate, and this shows kind of what would be mild, moderate, or severe. The percent of body weight loss is important, and we'll get a little bit more of that here in a few minutes. But definitely look over this. Again, this might be a helpful thing for you to print out and bring with clinical. I know at least I had one of those fancy clipboards that had you could open it up and stick all the papers inside that you needed for review. I don't know if anybody still carries those, but that did help me a lot when I was doing clinicals. So calculating the weight loss percentage. So something that I'm sure that everybody could do here without me talking you through it, but I'm going to do it quickly anyways. You just take that previous weight, subtract it from the current weight, and that gives you your weight loss. You take that weight loss number and divide it by that previous or initial weight, and you get a number, right? But we know that's going to be a 0.0 something. So you multiply it by 100 to get the percentage lost. So I have an example for you. Harper is a 7-year-old female who got admitted for vomiting and diarrhea. And the provider is trying to decide if they want to start some IV fluids or just try to do some oral rehydration. Mom happened to weigh her yesterday morning. She was at 23.5 kilos, and this morning her weight is 22.7. So we're going to take that 23.5 minus 22.7, right, which is this current one, and we get 0.8. So 0.8 divided by yesterday morning's weight, 23.5, gives us 0.034. We're going to multiply that by 100, and we're going to get 3.4%. So that's how much she's got on her weight loss percentage in the last basically 24 hours is 3.4%. So let's go back to our chart here. And so based on this chart, where does she lie? When we're not assessing her now, so you can't look at any of that stuff, but just based on that percentage, she's still at mild. So that's good. We're not super concerned yet. A nursing diagnosis as far as dehydration goes, things we're looking at would be a fluid volume deficit. That is your number one thing you should be thinking of for a nursing diagnosis. Other things to think about would be that risk for electrolyte imbalances, risk of ineffective tissue perfusion related to that blood flow, activity intolerance, right? We're not going to be able to do a lot of things. We're going to be tired. We're going to be cranky. We're going to be a little bit weaker. And then risk for impaired skin integrity due to that poor perfusion. So, excuse me, make sure, especially in infants, we're moving, we're rolling, we're doing things like that. So as far as interventions go for oral, first would be oral rehydration, right? We don't want to stick an IV in a kid if we don't have to. You can use oral rehydration along with IV fluids as well. So a way to help with that would be ondansetron, which reminds me of a reindeer from Santa. I mean, can't you just hear it? Like Donner, Blitzen, ondansetron makes me laugh every time. I did include in the reading for this week an article on pediatric rehydration in the ER that is very helpful, and it talks about the role of ondansetron in helping to rehydrate. So take a look at that. It's a pretty easy to read article, and it has some good information in it. So As far as the oral rehydration choices, if we are a breastfed baby, that breast milk is going to be the thing it's most used to. It's going to be more likely to drink that way. Formula, Pedialyte, and then low or sugar-free popsicles are all good choices. We don't want them hopped up on sugar as they're eating popsicle after popsicle if we can help it. We definitely don't want a lot of cow's milk or sugary drinks if we're having nausea, vomiting, diarrhea. Apple juice can actually worsen diarrhea, so that's something to think of. Now, if it's the only thing that this 2 or 3-year-old is going to drink, cut it with some water. Make it a 50% apple juice, 50% water, 20% apple juice, add some Pedialyte into it. That's helpful. Another thing that you may see on a pediatric floor would be the provider putting in orders for half-strength formula or quarter strength, meaning that their stomach is not tolerating their formula right now. They're unable to keep it down. But if we do half of that regular mixture and then half of Pedialyte mixed in, they may be more likely to keep it down. It's not as hard on their stomach, and we're keeping them rehydrated orally without having to do all of the IV fluids. So I think that's it for the recorded lecture. We are going to go over this all again on the 16th, and I will go through things maybe a little bit more in depth. Some things we'll just touch on because at this point you should have had some time to practice, do some research, do some reading, figure it out. I do have some more practice we'll do, as well as a big case study and a few other interactive things. So I don't have an official school email yet, but you can send anything on to Rebecca and she can forward it to me at this point. If you have any questions, you're more than welcome to contact me, let me know. And I think that's all I've got for now. So I will see you guys next week. I hope you're having a good week, enjoying this weather because it's phenomenal. And I look forward to seeing you next week. Thank you.